So in the last session, we talked about pretty much the interstitial stage, the early stages of pulmonary edema where the path of diffusion is impaired. And again, going back to Fick's law of diffusion, that can be countered to some extent with increasing the delta P, so oxygen therapy is beneficial. But the problem is when the edema continues kind of unabated in the water, again, the interstitial membrane, that membrane fills up, it's completely saturated, the water starts moving into the alveoli. So this is kind of, shown here. What you have then is some alveoli where the path of diffusion is now thickened. So between what's in the alveoli versus what's here in the capillary, that this distance is greatly increased. It's water filled, and again, these basement membranes get really thick. But then that become even worse than when the water now starts to move into the alveoli themselves. And when this happens, these alveoli cannot be ventilated. So among other things, the surfactant will be washed away, and simply water-filled alveoli will not be ventilated. And so what we're going to transition then to is the early stage, or the interstitial stage, moving into the alveolar phase, and water enters into the alveoli. And so it's indicated here, as I wrote for you, so water in the alveoli impairs ventilation. And so again, what you're looking at then is significantly decreased, in some cases, total absence of ventilation, but blood perfusion can continue almost normally. And so this is defined as shunting. And so the important thing is indicated here, shunt is not ventilated, but still perfused with blood. So the VQ equals 0. So shunting is VQ equals 0. And the reason why you have shunt then in the alveolar stage is again, once water ends up in here, these cannot be ventilated, but they're still being perfused. So what you start to see then, the difference is with diffusion limitation in the early stage, the alveoli, this would be the early stage edema. The interstitial stage is with diffusion limitation only. The alveoli can still be ventilated, but the path of diffusion is increased. And this is certainly responsive to oxygen therapy, and you can correct this with oxygen therapy, as we talked about. The problem is when you move to the later stage, to the alveolar stage, because of the edema in this case, the pulmonary capillary is not coming in contact with ventilated alveoli. So now what you have again is blood still moving through, but it's not coming in contact with ventilated alveoli. So this now starts shunting. And again, by definition, shunting means no ventilation but perfusion. And why is that a problem? Well, the question then becomes, how will oxygen therapy help you if you're shunting? And where oxygen therapy is beneficial in the diffusion stage, essentially, is it just as good or just as beneficial here in the alveolar stage? And so the way to think about this, again, is if VQ equals 0 and you're not ventilating, as we talked about previously in the other clinical session, if you give someone a high FiO2 of oxygen, 40% or even 100%, if they're not ventilating and ventilation is 0, it's not going to help them. So, and this becomes kind of to a larger issue with about shunt. So shunt is very bad. And in fact, of the 5 causes of clinical hypoxemia that we talked about, so we talked about hypoventilation and altitude, VQ mismatch, diffusion limitation, and shunt. Of those 5, shunt is the only one that is not responsive to oxygen therapy. And so people cannot benefit from oxygen therapy at a higher FiO2. And the question is why? Well, again, the ventilation is 0. When there's no ventilation occurring in that patient, all the oxygen in the world is not going to be able to get in and be able to help them. And so then the question becomes, at what point is a shunt become problematic? And so the answers vary a little bit depending on who you talk to or what you read. But it's estimated when we start to shunt, about 30 to 40% of our blood is being shunted. As we indicated, we do have a small amount of physiological shunt. Maybe 1 to 2% of our blood is being shunted under normal circumstances. Again, that's tolerable. It's not ideal, but it's certainly tolerable. So when we start to shunt about 30 to 40% of our blood, at that point, when we're shunting that much, the benefits of oxygen therapy is lost. So oxygen therapy will not be effective anymore, and is not in no way, again, is going to be an effective treatment when someone is not ventilating to that large extent, when that much of the lung is not being ventilated but still being perfused. And so again, what becomes an important aspect to understand is what really differentiates these two is that the early stage is still being ventilated. There's still ventilation being occurred, and therefore it can be responsive to oxygen therapy. When you get into the later stage, no ventilation is occurring. That by definition is shunt, and with shunt, you will not be responsive to oxygen therapy. And that's what makes this part of the disease really so bad for these people. Essentially, they're drowning from within their lungs with this fluid building up, and again, oxygen not being able to provide any benefit for them. And again, the important thing is water-filled alveoli will not be ventilated. Again, that leads to the shunt. Shunt, by definition, VQ equals 0. And when that happens, with VQ equals 0, unresponsive to oxygen therapy. So another thing about pulmonary edema is it decreases lung surfactant. And so we talked about with surfactant, it's important to reduce the surface tension and maintains an appropriate amount of compliance. And so the problem with the pulmonary edema is the surfactant is lost from the lungs. And overall, what this results in is a decreased lung compliance. And so, why is that? In water in the alveoli washes away surfactant. And what we know, this results in increased surface tension. We know this from, again, because surfactant is important in reducing surface tension. And so when we lose our surfactant, much like a preemie, we now see a significant increase in surface tension. As a consequence, there's now a significantly much more recoil in the lung. Again, that lung is very hard, very stiff. It's really hard to distend out, and therefore we know from our relationship, when there's an increased recoil, there has to be a corresponding decreased lung compliance. So again, if this is a normal compliance curve, this is a high compliance curve, and here's a low compliance curve, again, this is where pulmonary edema is going to lie. We fall from a normal compliance curve down to a low compliant curve. What that means then is, in order to maintain a specific change in lung volume, we'd have to generate more delta P, more work of breathing in order to maintain the same delta V. So by definition then, pulmonary edema is a disease that's characterized by an increase in surface tension, an increase in lung recoil, and a decrease in lung compliance. So what about pulmonary edema and the work of breathing? And so to kind of go back to this, we know that work is defined as our force times distance, which is our pressure times our volume. So the force we generate is the pressure that we can generate in centimeters of water, and the distance is going to be the change in lung volume. And so we know from our work of breathing, the total work of breathing is A, B, C, D, A. So we'll start, I guess we can go back to the blue curve, A, B, C, D, A. This is our total work of breathing. This is showing a pressure volume loop. So here's our inspiratory loop. Here's our expiratory loop. We know that the difference for this is hysteresis. We go up one side and come down another. We know that if we drew a line up through the middle of this, that would be our compliance curve. We'd have a normal compliance curve going through there. And so again, our total work of breathing is A, B, C, D, A. From this, we can determine that there's a certain amount of work being done. Given the fact that it's not moving over here to the left of the DA line, that's indicative of the fact that there's no work being done on expiration. And so in the case of pulmonary edema, what we see is we just talked about, there's a decrease in compliance. So the compliant line is now flatter than what it is over here, so a straighter line going up. So the compliance curve is flattening out, and that's consistent with a decrease in delta V for relative to a change in pressure. So overall, by definition, what we're seeing is a decrease in lung compliance. And then as far as the work of breathing, again, we have to follow our pressure volume loop. So we see now is A to B to C, back over to D, back to A. So significantly much more work of breathing in pulmonary edema. And the question becomes, where is that work being done? Is it being done on the inspiratory side, or is it being done on the expiratory side, or is it being done on both? And what we can conclude from this is it's all being done on the inspiratory side. By the line, the compliance dropping flatter, we're seeing much more area here to the right of the DA line, and also what we fail to see is any loops kind of coming off to the left-hand side of the DA line. So overall, then, pulmonary edema is a disease also characterized by an increased work of breathing, and all that breathing is done on the inspiratory side of ventilation. It's all done on the inspiratory side of ventilation. So what about trying to figure out is pulmonary edema, is it a restrictive or is it an obstructive lung disorder? So what happens in these patients then is when they're asked to, with pulmonary edema, is to fully inflate and do an FVC maneuver. Because of the fact that they're low compliant and they're very high recoil, they don't get up to a normal TLC. So they get up, in this case, to about 4 liters. When they go to blow out, because again, they're low compliant, they have very high recoil, they tend to blow their air out very quickly. And so what you see then is as they blow their air out, the air moves out relatively quickly, and they eventually come down here to residual volume. So what's shown down here are numbers. This would be the FVC for a normal individual would be 5 liters. Again, that's from 6 going down to 1. The FEV1 would be 4 liters. Again, that's after 1 second they went from 6 liters down to 2, so the difference is 4. And therefore the ratio of the FEV1 to FVC is 4 over 5 is 80%. What you then see in pulmonary edema, they can only get up to 4 and they come down to 1, so the FVC is 3. And again, this is really what they got to deal with in terms of normal function. Normal person has 5 liters. In this case, they're down to 3. The FEV1 is 2.7, so the ratio is 90%. And so then what we see is an FEV1 to FVC is greater than 80%. And the question is, what type of disease is that? Is that restrictive or is it obstructive? And so what we learned previously on these pulmonary function tests is that when we're over 80%, certainly over 85, 90%, this is classically a restrictive disorder. Again, when your FEV1 to FVC is higher than 80%, when it's higher than predicted, this is indicative of a restrictive lung disorder. And again, it makes sense. So what they're limited by is their lung inflation, and again, the reason why is they have so much recoil, so they can't get up near a TLC, and then when their diaphragm relaxes, they actually have a lot of recoil, and that's allowing 90% of the air to come out within the first second. And so again, it's overall the FEV1 to FVC is going to be significantly elevated. So decreased lung compliance and hence increased recoil restricts the ability of the lung to maximally inflate. In addition, the recoil results in a ratio of FEV1 to FVC that's greater than 80%. And by definition, this would be a classic restrictive disorder. So much like pulmonary fibrosis, pulmonary edema, again, is in addition to having diffusion limitation, causing shunting, decreasing lung compliance, increasing recoil, is said to be, or is classified as a restrictive lung disorder. So what about then understanding, again, as far as we've kind of talked previously, we've seen this graph before, so we know if this is total lung capacity up here, and this is residual volume down here, what's in between, again, is our vital capacity, and so we can determine this by spirometry, and on average about 5 liters in a normal person. So again, this is kind of the hand that we're dealt, and this is how much we have to play with in terms of the function that we can do. And we talked about diseases are characterized either where the ceiling is compressed down, resulting in a smaller vital capacity, or in some other diseases where the ceiling stays at the same point, but the floor moves up. And so again, the bottom line is you squeeze or you compress your vital capacity. And so the question is with pulmonary edema, what is it characterized by? As we just said, it's a restrictive disorder. That means its lung inflation is impaired. They can get nowhere near total lung capacity, as we saw in the previous graph. Instead of getting up to 6 liters, they may only get up to 4 liters. They may only get up to 4 liters. And so what that results in overall is pulmonary edema is a disease characterized by a reduced total lung capacity. So again, restrictives have a reduced TLC. Obstructives have an increased residual volume. And again, what pulmonary edema follows in being a restricted disorder, what you'd expect, or how you can also define it as, is it's disease is characterized by a reduced total lung capacity, and certainly not a disease that's characterized by an increased residual volume. So again, overall, pulmonary edema, a reduced TLC, is consistent with pulmonary edema. So what about treatments for pulmonary edema? And so as it turns out, we know that again, supplemental oxygen can help with diffusion limitation, but once shunt exceeds about 40%, supplemental oxygen will have limited usefulness. And the reason why is we talked about shunt is defined as VQ equals 0. If ventilation is not happening, if ventilation is 0, then all the oxygen therapy in the world is not going to matter. And we also talked about this in our clinical correlation lectures, that again, supplemental oxygen, if a patient is not breathing, has no utility or no usefulness for them. And in this sense, the VQ is basically saying that there's no ventilation occurring. And again, when that total degree of shunt is again exceeding 30-40%, again, you're really not going to have, at this point, oxygen therapy becomes ineffective. So again, it's good for the early stage, the interstitial stage of pulmonary edema, but not the later alveolar stage where there's significant shunting that can occur. So the loss of surfactant and hence the increased recoil may require positive pressure ventilation if the work of breathing becomes too great. We talked about how the work of breathing will increase in these patients, and it's going to increase on the inspiratory side, consistent with a restrictive lung disorder. And in some cases, if that work becomes too great for them to do, as indicated here, positive pressure ventilation, hooking them up to a machine that can do the work of breathing for them can be efficacious. So sometimes preload reducers such as nitroglycerin are used to dilate the veins in the lungs and other parts of the body. This decreases the hydrostatic pressure in the capillaries. So as we also said, the most common cause of pulmonary edema is left heart failure. When the left heart fails, all the fluid starts backing up into the lungs and in the pulmonary capillary bed. And initially, again, those vessels will distend and they'll recruit and try to keep their pressure down. But again, once they get overwhelmed, the pressure will start increasing, and that causes the hydrostatic pressure to rise. Again, something like nitroglycerin can be used to dilate those vessels even further to prevent the edema. But again, this just buys you a short amount of time, because ultimately what you need to get at is what is causing the heart failure, and get the heart hopefully be in a position where it can start to maintain appropriate cardiac output. But again, this is kind of a short-term thing, which it has great clinical benefit, where you can dilate, reduce the pressure. By reducing the pressure, you reduce the movement of fluid, again, from the blood, reduce the movement of fluid from the capillaries into the alveoli. So again, it can be used as a therapy, but again, really, if you want to change the overall trajectory of this disease, though, what you have to really get at is what's causing this pressure to rise. And again, in our instance, what we talked about was left heart failure being a cause. So you'd have to look at that. But again, you can buy yourself some time by dilating the vessels and decreasing the pressure. And with the issue being a lot of fluid, so a lot of times diuretics are used. When you get to renal physiology, diuretics will cause dumping of fluid from the body. So if you can reduce your plasma volume and get volume out of the plasma, out of the blood, that'll decrease your hydrostatic pressure. So simply just eliminating some of that volume, getting those vessels to kind of come back down, as opposed to being very filled with a lot of fluid. So this can actually work as well and can be an effective therapy in some instances, again, for pulmonary edema, to decrease that hydrostatic pressure that exists in the pulmonary capillary beds, and just driving fluid out of the capillaries and initially into the interstitial space and eventually into the alveoli. So with this then, to kind of finish up here, so other causes of pulmonary edema, so what I've talked about is increased plasma hydrostatic pressure as a consequence of left heart failure. And again, that is probably, certainly in the Western world, one of the most common causes of pulmonary edema. And so we've kind of gone through this pretty extensively, but just to keep in mind, though, there are also other causes of pulmonary edema. So one of the things is decreased plasma oncotic pressure. So decreased protein in the plasma, such as during malnutrition or hemodilution after saline volume resuscitation. So in a lot of third world countries where there's severe malnutrition, the normal content of proteins that exist in the plasma are not there. And what's important then, again, is these plasma proteins exert a certain amount of oncotic pressure. And what they do is to help pull the water back in and reclaim this water. If there's insufficient amounts of protein in the blood, what that means is that ability to pull the water back in is lost, which essentially happens now is a net movement out. So you can essentially get a pulmonary edema, not necessarily due to an increase in hydrostatic pressure, but a failure of the oncotic pressure to pull that fluid back in. And so again, certainly that can become problematic, and it can be another cause in addition to what we've kind of talked about is the increased hydrostatic pressure. Also increased capillary permeability. So a lot of pro-inflammatory cytokines or mediators such as histamine, bradykinin, some others, leukotrienes, can cause this. Can cause an increased permeability of this membrane. So really without necessarily not changing the pressure, the hydrostatic pressure per se, not changing the oncotic pressure per se, but just changing the permeability of this membrane, and you can actually get more water moving out, and that eventually can lead to a pulmonary edema. And the last thing we talked about is impaired lymphatic flow. So again, we discussed how fluid goes out, a certain amount goes out, almost all of it, maybe 90% of it is pulled back in through reabsorption, and there's a small minor percent, maybe about 10%, is taken away by the lymphatics. And although it's a small amount, that 10%, the lymphatics are very important because, again, given the high perfusion rate of the lungs, if that is allowed to build up, it'll build up very quickly. So anything that impairs the lymphatic flow, moving that fluid out, again, such as perhaps injury to the tissue, perhaps some type of tumor, anything, again, that's going to impair lymphatic flow and allows fluid to build up, again, can cause pulmonary edema. And again, that can be independent of an increase in hydrostatic pressure. So then the summary of the key points in understanding why for pulmonary edema it's characterized with decreased lung compliance, an increased degree of shunting due to a lack of ventilation for collapsed alveoli, Again, that's also characterized by a decrease in total lung capacity. It's a restrictive disorder, again, characterized by a decreased TLC. And understanding appropriate treatments for pulmonary edema can include oxygen therapy for the early stage, and agents that can decrease hydrostatic pressure are also useful again. And that can be, again, things that either vasodilate or reduce fluid. Again, overall, just trying to get at doing things where you're decreasing the hydrostatic pressure where the edema is being mediated by that effect. So that's it for the second session of pulmonary edema.